Hi, everybody. This is Erica Meloe. Welcome to episode number 46 of Tough to Treat. And we've made it to 46. My gosh, it's been crazy with the time has gone by so fast. And so grateful and thankful to all of our listeners and to those who have left us reviews on iTunes and have subscribed to our podcast. In order to move forward in the podcasting world, we rely heavily on those reviews and on people actually subscribing to the podcast. So if you've really enjoyed the podcast, both Susan and I would really appreciate it if you could leave us a review and or subscribe to the podcast. It would mean a great deal to us. Thank you. In this episode, we talk about a patient of mine who I saw at the end of last year who had some really interesting leg pain after some trauma, as you will hear. And what was interesting with her is, and Susan and I talk about this, is making a diagnosis and or a hypothesis of what's going on with this patient. And we should all do that after the subjective. It takes a while to hone those skills, and that is the hallmark, I believe, of a clinical expert, knowing exactly what is wrong with the patient before you even touch them. That is a beautiful thing. We also, at the end of the episode, we talk about what happens if a patient, upon your reassessment at the end of the treatment session, is objectively worse. Not subjectively, but objectively. So let's say you do a retest, you do a retest of something, and they're all over the place, although they feel pretty good. I guarantee you that person's going to come back worse. So what we talk about are tips and strategies for, doing, a quick reassessment at the end of a treatment session and giving the patient some strategies to work on at home that will really help them move forward and forward in their recovery, and also make your test retest much more succinct and clean. I hope you enjoy it. All right, enjoy. Bye. Hey everybody, this is Erica Meloe along with my co-host Susan Clinton, and welcome to episode number 46 of Tough to Treat. How are you, Susan?
I'm good. How are you?
I am good.
Very happy spring is here.
Yes, spring and the rain and the fog and everything else that goes along with it. And I just saw somebody in my elevator actually with these beautiful flowers. I was like, oh my God, I love flowers.
Mm-hmm.
Well, we're going to get right to it. So this is a patient of mine who I actually just saw her, and I'll just preface this ahead of time. I saw her for 2 visits because she was pretty good to go after 2, but I'm going to explain a couple of things because there was a 3 to 4 week time period between the first and the second visit. So I saw her this past August and September of 2018. She's 34 years old. She came in complaining of left lower leg and left shin pain, sort of like around the peroneals and the anterior tib, but she really sort of like ran that hand down below her knee along the lateral part of her shin. And her history, I think I mentioned she was 34. She was hit by a motorbike in December of 2017. So, you're talking maybe 8-9 months later. And from what she told me, she said she landed on the bike. I don't know how that could have happened, but she did. And that's what I wrote. And she also then rebounded and landed onto her left side, her leg probably slid from under her. And onto that left lower leg. And she basically complained immediately after a deep and significant bruising. And it took about 3 to 4 weeks to recover, quote unquote, from the bruising. And she saw an MD and they did, some x-rays and things like that, but they didn't really find anything. Her lower leg was so swollen that they probably wouldn't have been able to see anything.
Mm-hmm.
Anyway, she's very, and I put very in here, and I'm quoting her, very hypersensitive. And she said she was having a slow return to exercise. So her body type was, very sort of lanky, very petite, thin, hypermobile, that sort of body type. And her big exercise was the elliptical, and she was very slow to return. When she was on the elliptical, she felt she couldn't use her leg. She didn't use the word dead leg, but she felt like it was just not part of her body. So she also complained of about 2.5 weeks of her Achilles being sore with the ankle, probably just the whole left lower leg just got really aggravated. No prior medical history except she's a horseback rider. And she's actually from Houston, Susan. And the past medical history that I always ask for, and she actually volunteered, she had multiple ankle sprains, like 3 times on her left ankle and at least twice on her right. And probably from field hockey and lacrosse, because that's what she used to play as, probably when she was in college and in high school. And she also had an old past medical history of a left hip flexor strain, same side as the leg pain. But it was really a traumatic incident with MVA, or the motorbike accident. What aggravated her was walking and the elliptical. What eased her was ice and getting her body in Epsom salts. Okay, and no pins and needles, no numbness. She didn't complain of any buckling or any weakness in the leg, but I did discover that there was some significant weakness. Should I go on, Susan, or do you have any questions?
Well, my first question is, with the deep bruising and the lasting hypersensitivity, did she talk about a compartment syndrome at all?
No.
Okay,
she had no intervention at all, no PT, nothing, just that one visit to the doctor.
Okay, so there wasn't any of the swelling and the stuff that they would have really had to work up for compartment syndrome or anything. She would have known.
Correct, because I think it was a traumatic issue. They wanted to make sure nothing was fractured. So
something that is standing out to me with the way that she hit, and the fact that she did have the deep bruising, and there is a lot of hypersensitivity, that I'm just wondering if she had a bit of a degloving injury. Where that fascia was pulled.
Interesting. Yeah,
with that deep bruising like that and that hypersensitivity. So those are my thoughts, just kind of as you were talking through her history here. So,
yeah, I love when I think it's great. I just digress for a second. It's great when we give everybody the history, and then we could all kind of guess as to what the issue is and see how good we are without even looking, examining them. I think we would probably have a high, success rate with that. I know we need to objectively assess them, but
right. So with that, possible degloving and the fact that she talks about that her leg just doesn't feel as good when she's, exercising, which is walking and elliptical.
Yep.
Because I'm just thinking with the deep bruising and the stuff, there may be, I don't know, it just seems like, was her blood flow compromised in any way? I mean, even a little bit can make you feel pretty bad.
Yeah.
Kind of in how it heals. Did she complain of any, I know we'll talk about the objective exam in a minute, but did she have any swelling?
Oh, big time.
Yeah. And so some of that, so there could have been a little bit of some nerve injury stuff going on just because of the swelling. There's not a lot of room in that lower leg.
I know.
Even if it doesn't turn into a big compartment syndrome, there's still not a lot of room.
I know. You would think, though,
those peripheral nerves are pretty, especially on the lateral side, are pretty superficial.
Bingo. Exactly.
Yeah.
Exactly. And you would, in the past, she had a significant traumatic. She fell. Could she have, injured her lumbar spine or hip? Yeah, maybe. But at this point, she was not 8 months post accident, and that was her main issue. And I mean, just looking at it, so her peroneals and her lateral shin was so swollen, and I put my hands in there. I mean, I'll talk about what I saw in standing, but since you're mentioning it, it was boggy. I mean, it was like I wrote boggy and mushy down for the clinical terms, because I mean, it was like thick soup. And it was obviously swollen, still that long.
Yeah, so lymphedema or lymphatic system injury for sure, and that also occurs with that degloving kind of thing.
Yeah,
where they scrape along the sidewalk and stuff like that.
Yep.
Hitting the bike and then rebounding and hitting the ground, and that there was some bounce and slide that happened. So okay.
Yep, totally. So she did walking, and I knew from the timing that she saw me in mid-August, she was going to go back to Houston for a few weeks. She's an actress here in New York, and wanted to go home to Houston, see her dad. And so I knew before I even put my hands on her that I needed to give her something to do for 3 weeks, because it's not like I could finish the evaluation up like the next day or the following week. So usually when people have issues with walking,
I will look at, one-legged standing. I will look at step forward. I will watch them walk. Okay. I will do that. But she had issues in standing when she was presenting to me. So because of the time issue, because I needed to give her something, quickly, I did not look at one-legged stance in this particular evaluation. And I would have normally. So just preface that in case anybody, because I usually do that. So in standing, obviously, her center of mass was way off to the right. No surprise there. As was her entire head and thorax, just completely shifted to the right. Same, once again, no surprise. She had a little bit of a pelvic obliquity in terms of she had a transverse plane rotation to the left in her pelvis. Once again, not really relevant, but it was how she presented in standing. I had her do a couple of, I just tried to clear the lumbar spine. I had her do some back bend, forward bend, just quickly, because I had a pretty good idea from the subjective of what I think what the issue was. So I tried to clear everything out in the lumbar just because she was going away. No problems, forward bend, backward bend, nothing. I literally, I just said, can you do a squat for me? Just show me how you squat to the floor. No problem. I had her do a body twist, a significant, so in standing, just complete rotation all the way, try to move the lower limbs, no problem there. And because of the issue with the lower leg, I tested her, I did a heel raise, I tested her calf strength because of where the symptoms were, and because walking involves some push off. So her right, and I don't normally do a ton of manual muscle testing, to be honest. I will generally assess it, but her left side was like barely 3-. I mean, she could not even go against gravity. Her right side was a good 4 to 4+. So obvious weakness there. Okay. And she was sort of cheat and go up into inversion, classic. So I wanted to get my hands on there, and I wanted to do some adverse neural tension testing. I wanted to do it. Could I have done it in sitting with the slump? Yes, I could have, but I didn't. So I had her on her tummy first. I just went on her lumbar spine just to clear it. No problem, zero pain, zero, nothing. I found nothing, which I expected. And so I had her turn over, and I just got my hands on there, and she was really super sensitive, really swollen. I just put my hand on her fibular head, and I was like, very sore on a lot of people, obviously super sore on her. So I went in and I tested. I went to straight leg raise, and I just went for it because she was like 8 months. Straight leg raise, hip adduction, internal rotation, dorsiflexion, inversion. I wound her all the way up. And she went through the roof. So, I mean, not in a bad way, but that was like, oh, that's my issue. That's my issue.
Yep. No surprise there at all.
Right. Exactly. So when you mentioned the peripheral nerve, I was like, bingo, that's exactly what her issue is. Okay. And she had a couple of other things, but that is the first thing that I went for. And I tested the sural nerve or the peroneal nerves. There's a bunch, the tibial. I mean, we can go into all the peripheral nerves, but they were all ragingly positive. Okay. And it's no surprise that her calf was weak. Nothing was firing down there. And when you're so swollen, it's really kind of hard to recruit muscles that are bathed in fluid, to be honest. So that's actually what I did for the objective for the first day. I mean, not my usual fare, but it was just obvious, I thought, from her subjective, what I felt the issue was. Do you have any comments or questions?
No, how swollen was she compared to the other side? And was it just localized to the lateral part of the leg, or was it like the whole lower leg was just swollen foot?
No, it was localized to the lateral part of the leg.
Okay, so the foot wasn't swollen.
No.
Or those kinds of things, just along that side there, like
Correct.
In that lateral compartment.
Yes, and I should have done a circumferential when I didn't.
That's okay. No, I'm just wanting to. I just basically what I was wondering if the whole foot was swollen, or if it was just just in that lateral leg. Okay.
Yeah.
No, that's good.
Lateral leg. So that's why, and I could have done all of that in sitting, but that's why I kind of went into, and I was checking her because she was so long. If this happened 2 days ago, I wouldn't have wound her up so much, but
right.
I kind of went in there, and since I don't know about you, but I noticed with a lot of these hypermobile patients, they have nerve issues. There's like a lot of peripheral nerve issues, and that also, yes, right. I will count myself among those as well. So those were positive. So what I ended up doing, and because of the time issue, and she had to go, I gave her basic nerve glides to do. So
Mm-hmm.
what I ended up doing, I did a little soft tissue work in the peroneals just to sort of get some of that fluid pumped out. And obviously ice was helping, but she's like, Erica, the ice is taking it away, but then it's coming back again. I'm getting the swelling, and it obviously depends how long she's on her feet, right?
Mm-hmm.
So I basically gave her, hip flexion. I gave her a couple things. I'm looking at my notes. Hip flexion and so she's in the straight leg raise position. Her knee is flexed. I gave her, and then her foot was dorsiflexed and inverted. And then I just had her do basic knee flexion extension.
Mm-hmm.
Okay. And then I basically had her do the knee extended, hip, straight leg raise, knee extended, and had her do inversion, knee version. I was like, make it up, have fun,
Move back and forth, explore it, bring your leg this way, bring your leg that way.
Exactly. I said, you know what, you're going back to Houston, just you can stand and do these things. I gave her some pictures out of David Butler's, one of his books I have, of some standing nerve glides.
Mm-hmm.
And then I also gave her, I said, just move, just you don't have to do a lot of this in standing. A lot of this in sitting or on your back will do. If you want to do it in sitting, I showed her how to do it in this sort of slumped and position in sitting as well as in extension. But her big thing was, she felt it more in supine, which makes sense. So she went home with that. Okay. I didn't see her until 3 weeks later. So, or actually almost a month later.
Okay.
And so she was in Houston, obviously not as much walking as here. She told me she felt a lot better, that she was quote unquote less mushy. This is what she read, less mushy. But now she's walking, she started to walk back in New York, and she was getting some mild pain back, but it was much better. And her tightness in her Achilles was coming back a little bit. So that's how she presented the second visit. And that was her objective. So I said to myself, let me test her calf raise. Let me test some of the neural tension, because let's see if it is truly better. I mean, in terms of provoking her symptoms. And the calf raise was completely normal. I was like, oh my God. I mean, it was normal. I mean, like a 5 out of 5. So I was like, yeah, that's what some little nerve gliding does for you.
So do you think her lack of power was inhibitory because of the pain?
I think so.
Because you certainly don't get muscles back that fast.
Exactly.
So that kind of
and I put an exclamation point. Yeah.
Yeah, that it bothered her to do it because it put those tissues, on a stretch, and the hypersensitivity and the pain, could have kept her from like having the power to do it without really. So it just tells me that it wasn't really a strength problem. It was more of those nerves that just needed to glide and move with less sensitivity so that she could actually access the power. Because, a heel raise is basically posterior compartment, not really lateral.
Yes.
So,
exactly.
So that's important. I like that, because in going up on the, that is one of the exercises you gave her, laying on her back with a straight leg raise, pointing the toe going into inversion, eversion, so that's, as you go up onto your toes, lifting your heels, you're taking them into that neural glide, that downward glide that occurs, because everything's getting drugged down across the top of the foot. And that's where the lateral nerves all go.
Yep.
Around the top of the foot and over the top of the ankle and stuff. So cool. That's exciting.
Yeah, she was.
What a big change! Yeah,
I know. I was like, and I put an exclamation point in my notes. I'm like, oh my God! And I do agree. I think with the fluid, and I mean, you bathe a joint or a muscle in fluid, it doesn't really like it. Even nerves, they're very, very cranky when they're swollen. So I do think once that swelling was down, then the nerves said, "Oh, I feel much better now, and I can actually fire." So I agree with you there. So what I did this time, because she was here now for some time. I actually watched her, because she's a fast walker, and I actually watched her take some really big steps when she walks. And I've mentioned this in the past, that sometimes when people have problems walking, I'll have them take overly large strides, because sometimes things jump out at me when I do that, and I had her repeat that with a bit of a lunge, and then I had her repeat that with some rotation. So for example, when the left foot went forward, the right arm went across her body. Just, basic reciprocal movement. And when she stepped with that left foot forward, rotation to the left was really hard and she was really off balance. Once again, wasn't surprising.
Mm-hmm.
Then I tested her in sitting. I just tested her thoracic rotation in sitting because of the sympathetic system. I tend to go and look at thoracic rotation, especially when people have issues with walking. Not immediately, but I will do it if like she was so much better the second visit. I was like, I need to make sure, because she's a working actress in the city, not a ton of time to really devote to this, but she obviously wanted an answer anyway. So she's really hypo mobile in seated left trunk rotation. Right was normal. Excuse me. So what I ended up doing was I rechecked the glides. They were not as provocative as before. I had to really, really wind her up and hold like a complete tensioner and wind her up before it really set in. And even then, it wasn't really that much. That bad, but she was still getting some mild issues with walking. So then what I ended up doing was I turned her over, and because of the thoracic issue, because she was so, my guess at this point, I know I'm rambling, but I felt that because when she was taking those big steps, she couldn't really balance onto her left foot. Maybe it was because of the lack of thoracic rotation. I don't know, because who knows? So what or
maybe the lack of rotation set up because she wasn't wanting to be on that foot. So
Correct.
It's like it's just the pattern that has developed since the pain experience.
Correct. And her center of mass, I always look at people's center of mass because, as I said before, sometimes if you stand them up after a session, like if they come into the session and they're like way over to the right, and you do what you do in your treatment session and they're centered, I'm like, well, you're not making them worse because you're at least centering them in some way. So, and people could argue with me about that, but that's just my clinical experience. And so when she came in after the second time, she was pretty centered. So everything was better. So I was like, well, I need to dig a little deeper here because there's maybe 20% of something I've missed. Or is appearing now that she's much better. So what I ended up doing is I did give her again those nerve glides, and I wanted to see why she was so limited in that left rotation. And it could be, it could be that she had hyperactive external obliques, which would be very common. She also it could be some issues with her thoracic spine. I highly doubt she had a stiff joint in her thorax. She's hypermobile. It most likely was somewhat compensatory. So what I ended up doing was I said, look, I need you to find something that when I perform an intervention that we can retest to see if
it got better or not.
If it got better or not. Correct. Because her nerve glides were better, it wasn't as sensitive as before. So that wasn't going to work this time. So I ended up having her do so she did a lunge, for example. So left foot forward lunge, and she sort of like a walking lunge with rotation. That was it. And she goes, that's really, really hard. I'm like, okay, that's going to be whatever your self-check for whatever that's worth. Okay. So I ended up doing various forms of the nerve glides again. I actually turned her over, and I did some, you can call this whatever you want. I did some joint mobilization to her thorax, her upper thorax, just not because she was stiff, just because I wanted to see if I could intervene into her nervous system to see if I could reduce any of the muscle tone in her upper thorax, because she had a lot of increased tone in some of those muscles up there. That's the only reason I did it, and I did it for maybe 5 minutes. Okay, that was no other reason, because she's not stiff at all. So I ended up doing that, and whether that helped or not, I'll tell you in a second. And then I turned her over, and then I did a little bit of some release work in her external obliques, primarily on her right side, her right external oblique. And then I said, we need to do some movement here. So because she did some Pilates and yoga, I ended up having her lie on her side and do what we call, so she was going to be right side lying, doing some left trunk rotation. I call them book covers. So right side lying, hands out in front, doing some sort of, I call them book covers, book openers. Then I had her do child's pose with her hands to the left, just to sort of open up that right side a little bit. No reason. That's just move. Responded so well to the last intervention, and I learned that with somebody like her, less is more. And I also did some work on her peroneals as well. Pretty much, so this second treatment consisted of the soft tissue work to the peroneals that I did the first visit, more nerve glides, they weren't as sensitive, and then I did some work in her upper thorax, and then I did some movement, okay? So thoracic book covers, child's pose. Then I had her go into standing, because sometimes people can't, it's not practical to give them some of these things inside lying. So I had her stand and have her hands against the wall and do almost like a bow and arrow, but it's more like, opening like thoracic rotation against the wall. And she did pretty okay with that. So I ended up saying, let's just do your self-check. Let's just do the big steps or the lunge with rotation to the left. And she did, and she was perfectly fine. She had no problem with it at all. I rechecked her calf raise just to make sure I wasn't making anything down low worse. So the reason why I mention that is because lately I've been seeing a lot of patients where, because they're quite complex, where you intervene at a certain point, whatever body part or whatever section of their system you intervene in, sometimes it makes other parts of them worse. Mm-hmm. So because they're that sensitive. So with her, I wanted to make sure that her calf raises were still good, that that the muscles weren't inhibiting, that her nerve glides were good, and they were fine. So she was fine with that. Gait was fine. Lunge with left rotation was fine. Calf raises were fine. I rechecked the nerve glides, really 99% better. Mm-hmm. Okay. So if I had made her calf raise worse, I'm just throwing this out there to the audience. If with doing that work, with the addition of some of the work in the thorax and just opening her up to the left, if that had made her calf worse, I know what I would have done. What would you have done?
With me?
Yeah. Okay. I'm just curious.
Yeah. First of all, you followed kind of the way that I would have gone. I would have gone up into the trunk next.
Yeah.
To get into the thorax. But I would have either had to take a step back and go either two different ways. Mm-hmm. Number one, I would take her the opposite way in her trunk. Mm-hmm. Rather than rotation. Into it. Yep. Yeah. I would just go into the opposite way. Sometimes the indirect direction can be very helpful when you stir something up going a certain way. So I would spend a little bit more time going the opposite way. But the other piece that I would do was I would have gone up to the neck and gotten the neck to move and kept the trunk still. If I could have settled it down that way as well. So those would have been my two things to do.
Yeah.
Because sometimes it does happen. Sometimes it could have just made it a little bit worse because you were getting into a higher level of the nervous system, into where some other neural tension-y things could have been. Who knows? I mean, she flipped on this bike, or she hit the bike, and then she went in all different kinds of directions, and she's been kind of just staying in this one movement pattern for a long time. So it's always wise to test out that movement pattern and just see, can we tweak it? And if we can't, can we tweak it another way?
Right.
Because sometimes I have found that going complete opposite direction or to a complete whole different region, can have wide effects on that without having to go right into an area where, for whatever reason, she may be still kind of protecting pretty hard. But in her case, it didn't happen. So
exactly. But that's why I bring it up, because sometimes I think that because people can be so sensitive, maybe it was a good thing I didn't see her for 3 weeks, who knows, but her calf raise was fine. But there are people who, you've got 5 or 10 minutes left and you're checking, and that's why it's so important to recheck things. Leave yourself time at the end of each session, because they're going to come back to you, or they're going to send you an email, or they're going to call and say, this is worse, or doesn't make, trust me, they do. Okay. Mm-hmm. So with somebody like her, she was fine, but I'm saying, let's say she wasn't, right? I would have done the same thing. I would have also, I think, because she had an accident and she had no intervention. She got an x-ray in the ER, for God's sakes. That was it. And she lived with this for how many months and wasn't getting better. Yes. I mean, she may have had some PT. I don't remember. I didn't write it down. I usually do. So the fact I would have gone the opposite way, I would have gone to the neck. I also would have gone back to the nerve glides, just because I don't know. That did help her the first go around, just to see if there was something that was just not moving well. But I do agree with you. I think that we need to do the opposite, go with the opposite motion,
Mm-hmm.
go up to and go up to the neck, because people do get worse. They do.
Yeah.
They'll say, "Oh, my back pain's on my right side. Now it's on my left, or now it's up in my." That happens a lot.
Right, and that's that brain smudging that comes along with the, the persistent pain setup.
Yep.
And they're just, you just have to kind of get their, have them explore those movements. And if that one way doesn't work, then let's explore it another way.
Right.
And I think that it's okay to go. It's like, well, but she turns okay to that side, so that's good.
Yeah.
It's something she can do that's going to keep things moving.
Exactly.
That wasn't before. So maybe she can just explore going to the left just a bit, but not going as far as maybe we took her in intervention, So, okay, so let's settle that down to just this much.
Yes.
Now let's see what happens and see if that settles down. Because sometimes people take things to the, they think, okay, if I move over this way, then it hurts. I should just keep doing that, and it's like, well, maybe not. Let's kind of back it up a little bit. But having that recheck exercise can be super helpful, because then they can know, like, oh, I've overdone it. Let me see how I am with this. Yep.
Mm-hmm.
So what were my things to do to settle down? Oh, that's right. Go the other way and do some other things, so.
Exactly. Like
it helps them figure out their movement patterns better, because you give them kind of the, some tools and scaffolding to do that in, then they can kind of begin to navigate those waters a little bit cleaner.
Mm-hmm. Yep.
So,
yeah, I agree. Yep. And I think with her, that was the issue. And I think it's imperative that we leave time at the end. I know it's easier said than done, but just to leave time at the end, because pick a movement, whatever movement you want to pick, you need to reassess it. I know it's obvious, but a lot of people don't do it. And especially with some of these super sensitized types, as well as the ones who've had persistent issues, because they're going to walk out of there and they're going to not be happy. So,
yeah.
But luckily for her, she was, and I actually emailed her. So that was my last visit with her. I emailed her like a week later. She was good to go, no problems at all. And I was like, that was the quickest nerve 2 visits ever, because I don't know. I felt like because she had a time issue and because she was going to Houston, I went with my gut based on the subjective. I tend to sort of look at everything, and that's what I do. But with her, I felt that it was important. Her subjective really guided, and that always should guide what you do objectively. However, it really did this time, because I didn't do certain things that I normally would have done because of this time issue. And I said, I need to intervene, and I need to do it. And I have an hour. Okay. So that's it for her. And I've been meaning to talk about her for a while, because I think, because I wrote down in my notes, I rechecked the calf raises, and then I put a little question mark for the podcast saying, what if she wasn't better? What do we do? And I think that's always important to ask. What if her calf raises? What if she wasn't better? And you have 5 minutes. What do you do? You go in the opposite direction. You do. And I think that's the big thing besides the obviously subjective issues. I mean, for the listeners is, all is not lost if you just do a self-check and get them on their way. And generally with these types of patients, they usually settle down. Their nervous system settles down.
I think it's great. Thanks for sharing that.
You're welcome. You're welcome. So everybody,
good ideas. The only thing that that people may be out there thinking about is, would you have considered using compression garments? And I can tell you my answer on this.
Okay.
Is I might have considered a compression sleeve or a garment on her leg, just because it could kind of help mobilize the fluids a little bit. But she was so hypersensitive that I don't know that she would have tolerated it.
Right.
So you have to kind of pick and choose that a little bit.
Yeah.
People who are super hypersensitive don't tolerate tape or.
That's exactly right. And I think this is the first time I actually didn't tape anybody, so it's a shocker.
But people may be having that question out there, and that would have been my reasoning behind it, was at least not at this point. If she had come back and still had the swelling, but the hypersensitivity was better, because that could have been a presentation that would have been very plausible as well.
Yes.
Then you could consider, well, yeah, let's go ahead and slide just a 10 millimeter of mercury, compression, sock on and see if that doesn't help mobilize those fluids along, maybe add some clearing of the lymphatic system a bit.
Yep.
But
absolutely.
She seemed to get the nerves rolling, and the swelling changed and her movement changed, and so don't need to do all those other things.
Yeah.
Just kind of give it an eye, and she knew what to watch for and what to do now, and she kind of knows. She knows when she's pushing and getting into a bit of trouble. So, but you gave her real good things to do to get herself out of trouble, which is really important because we're not going home with them.
And especially after I get a lot of people wait to the last minute and they're like, I'm leaving for vacation in a week. Are you kidding me?
They always do that.
They always do that.
That's human nature.
Totally. So you know what? You have to sort of, what's the word? You have to adapt.
Yep.
You have to adapt. And those are my parting words for today. We have to adapt.
All right.
Totally awesome. And I want to thank everybody once again for listening. And we were really, really trying to get our testimonials, our reviews up on iTunes. So if you have not left us a review on iTunes, please, please, please do. We would so appreciate it. Even if it's a few words, great podcasts, love them, whatever. If you really have gotten a lot out of it, we would urge you to write the review and to subscribe to the podcast as well. So we are now on Stitcher. I'm trying to get us on Google Play. I didn't realize that Samsung users only use Google Play. I don't know about you, but someone said to me, you need to be on Google Play, because I said, okay, so we're
still learning.
We're still learning. So,
yep.
And obviously iTunes and Spotify. So we really want to get the subscriptions up and the
so others can find us.
Totally. Yep. I think we're one of the only podcasts out there that does this type of banter back and forth and clinical reasoning through patients, and it's a great asset to the podcast community. So we're really trying to push things forward. So we would really need your help in that. So thank you.
Thanks, everybody.
Right. Bye.
Bye. Bye.